Hello, and welcome to the Duke Endocrinology Conference. I'm Diana McNeil, Professor of Medicine at Duke University Medical Center. Today's program is entitled Controversies in Assessment and Management of Aging Patients with Type 2 Diabetes. And our distinguished guest is Susan Braithwaite, visiting clinical professor at the University of Illinois, Chicago, St. Francis Hospital, Evanston, Illinois. Susan, thank you so much for joining us.
Well, it's a tremendous pleasure and privilege to be here today, and thank you for inviting me. Today, our topic is to talk about the problem of diabetes in the aging patient. I'd like to review current guidelines for the treatment of diabetes in the elderly patient and to talk about the assignment of glycemic targets that are appropriate to the patient's condition. Also to discuss the precautions and the potential complications of anti-hyperglycemic therapy in the older age group, about the treatment of hypertension, which is beneficial to these patients, and about the extent to which we should be screening for complications that could lead to functional impairment, with a focus on those complications that there would be a treatment for that would pay off for these patients. There are a couple of very good resources that I would like you to know about that I have listed here. The most recent Standards of Medical Care in Diabetes, published in Diabetes Care in the January supplement, takes as its basis the earlier article by Brown and colleagues, and much of my talk is taken from the very short statement in the Standards of Care from the American Diabetes Association. Much of this is not yet evidence-based, and so I will be giving some opinions as well.
I'd like to tell our audience that the Standards of Care comes out every year and actually is a wonderful resource for all types of information. Don't you think, Susan?
Absolutely. I think everybody in primary care or in endocrinology or diabetes should be aware of that. Well, diabetes is an important health condition for the aging population. At least 20% of patients over the age of 65 have diabetes, and we expect this number to be growing rapidly in the coming decades. This slide from the NHANES survey shows the high frequency in the 75 and older age group for both men and women. When the A1C is looked at in a cross-sectional analysis at different age groups, it can be seen that the A1C rises continuously with age. This appears to be a continuum even before the onset of diabetes. And when a subgroup of people is examined from the Framingham study shown in the bottom panel on this slide, where there was available data from glucose tolerance testing, even in those patients who were shown to be not diabetic, nevertheless, the progressive rise over the decades of age shows the A1C to increase with age. And when a cohort of patients from this study was followed, it was seen also that that cohort experienced a gradual increase of A1C with time.
Susan, these are patients that did not meet the criteria for having diabetes. So why would your hemoglobin A1C go up as you get older?
Well, it's questioned how this should be interpreted. One might say that they're on their way to having diabetes. On the other hand, the authors question whether we ought to think differently about this possibly. The diagnosis of diabetes was based on the threshold at which complications begin to be seen, using retinopathy as the threshold that was the easiest to tag to the onset of the disease. So it really needs to be asked separately for this age group whether the A1C standard should be the same as for everybody else for making a diagnosis of diabetes. But right now, the interpretation is that at any age, the A1C threshold for diagnosing diabetes is at this new 6.5 threshold, which now is one of the ways that diabetes can be diagnosed.
And that's actually an important probe for our audience to remember.
Yeah. If nursing home residents are looked at, we also find that there's a high incidence of or prevalence of unsuspected diabetes by doing informal glucose tolerance testing. Some of these were done using capillary glucose measurements so that they are not quite the same standard that's used for diagnosing under the ADA standards. But still, if you look at nursing home residents, 12% in one survey had known diabetes, and when glucose tolerance testing was done this way, 14.8% were found to have newly detected diabetes, And in another similar study, 8.2% were found to have newly detected diabetes. But if a subgroup was taken that had dementia, then it was an even higher fraction that had unsuspected diabetes.
So we may be missing it quite a bit in our nursing home population.
That's
so that
right.
The original number that you told us, the large percent having diabetes at 20% over 65 may actually be higher.
Yes, that's right. Yeah. It may also be that the form that diabetes takes in older patients may differ from typical type 2 diabetes in younger patients. And of course, some people do have type 1 diabetes, either having had it all their life or developing it at an older age. This first slide shows the relationship between fasting glucose levels and the hepatic glucose production. If one took type 2 diabetes patients at a younger age group, all of the black circles would be higher up, not all of them, but the average for the hepatic glucose production would be abnormally high in the presence of fasting glucose elevation, not at about the same level as other non-diabetes people of that age group. But in the elderly, it appears that even though you could say that there's inappropriate hepatic glucose production, it is not elevated above the level that one would see in a non-diabetic person. So that the elevation of hepatic glucose production is not as pronounced in this age group as it is in younger people having type 2 diabetes.
For those of our audience who don't always think about hepatic glucose production, could you remind them which of the blood glucose measurements that's most often correlated with?
The fasting blood sugar is the easiest way to see hepatic glucose overproduction in the fasting state. Of course, inappropriate hepatic glucose production can occur in the non-fasting condition as well.
Absolutely.
Another point that differentiates perhaps older people with type 2 diabetes from younger ones is that in the older ones who are lean, there may be a difference in insulin secretion. This slide shows both in lean and overweight patients that the first phase insulin secretion is abnormally blunted, which is characteristic for diabetes in general, type 2 diabetes. But the late phase of insulin release is more severely abnormal in the individuals that are lean who are older compared to the obese older patients, as the red arrow shows.
Does this make us think that the lean patients behave more like a patient with type 1 diabetes?
Well, it's even been suggested that we should think of them more as a type 1.5 or behaving more like a type 1. They may be not ketosis prone, but yet in the sense that they have a stronger line of evidence for insulin deficiency than their obese counterparts. That seems to be a possible interpretation. And here, too, along those lines, Dr. McNeil, the insulin sensitivity of the lean older person with diabetes appears to be greater, and the insulin resistance of the obese individual appears to be greater. So that the insulin sensitivity of a lean type 2 patient is more like a type 1 characteristic. The significance would then be that you might find some patients who are behaving a little bit more like a type 1 diabetes patient, even though they really had, we had thought all their life type 2.
Which would have some implications for what I think you're going to teach us a little bit later on about the choice of therapy for some of these patients.
Yes.
And how we manage them perhaps in the hospital or even the nursing home.
Yes. One might first think of sulfonylurea for somebody who is insulin deficient, but then in thinking about insulin therapies, one might go at an earlier stage to providing prandial as well as basal coverage for someone who was thought to be insulin deficient.
So this is really key information for us and trying to rethink our management of our elderly patients. I think that's very important.
Well, now I want to spend a minute on the concomitants and the consequences of having diabetes and its treatment as an older person. Compared to those who don't have diabetes, older individuals have higher rates of premature death. There's a higher risk of cardiac deaths in these patients. The rate of death is probably twice, or the mortality rate is probably twice that of other patients at this age group. And if a diagnosis of type 2 diabetes appears after age 65, on the average, the life expectancy may be shortened by about 4 years compared to non-diabetic individuals in the same age group. There's a greater risk for functional disabilities and for coexisting illnesses such as hypertension or heart disease or stroke.
You see a link here with a lot of our vasculopathies as we get older. I didn't realize the data about over 65 that you had shortened your life expectancy. I think many of our patients assume that if they've made it through so far without getting diabetes, that their life expectancy is not altered by that.
Yes, but then with the onset after age 65, there still is
Yep.
a reduction in life expectancy. There are other issues for a person having diabetes at an old age, including polypharmacy, much of which is imposed by the treatment for diabetes itself. And then depression accompanies diabetes more than it tends to appear among other older patients. Cognitive impairment may have several different types of causes. We think about the possibility of vascular dementia in this age group, and then there may or may not be an increased incidence of true Alzheimer's. There is suggestive evidence that there probably is an increased frequency of Alzheimer's itself. We worry about depression or other things that can mimic cognitive impairment. Thyroid testing probably should be considered if somebody seems to have cognitive impairment, as with any older person.
Right.
B12 deficiency, and then the effects of hypoglycemia have to be considered. Urinary incontinence is exacerbated, especially in women, by having diabetes. Injurious falls may be multifactorial in the elderly person with diabetes, with neuropathy, with visual impairment, and with hypoglycemia.
We've been struck in our clinical practice by the prevalence of the vitamin D deficiency syndrome, and I think, particularly for the evidence that suggests that may be associated with increased falls. I think many people have started to check some of our patients with diabetes in the elderly more frequently for 25-hydroxy vitamin D deficiency.
Yep.
That's a treatable problem.
Yeah.
It will relieve a lot of those issues that you mentioned up there.
Hypoglycemia is well known in the elderly to sometimes have more serious consequences than in younger people, and fatalities, especially with certain classes of drugs, including sulfonylureas. The first-generation drugs are especially a problem for older patients. Chlorpropamide should not be prescribed in this age group. And among the later drugs, it appears that glyburide has the highest risk of severe and persisting hypoglycemia, probably having a more persisting action than do the other two alternatives, glipizide and glimepiride. In thinking about the factors that predispose an elderly person to hypoglycemia, these might include erratic nutritional intake, mental status changes, polypharmacy, dependence on others for meals or for treatment of hypoglycemia, and then impairment of both renal and hepatic function, or secondarily that those organs may be affected by cardiac failure with the result that drug excretion is altered, and then other comorbid conditions that can mask hypoglycemia.
I just got off, as I was telling you, Susan, the inpatient service, and we saw many patients who were doing okay and then had just a medication adjustment, or they got a little bit dehydrated, and then the hypoglycemia just seemed to be more prevalent. And I think your point about them patients not always recognizing the hypoglycemia becomes remarkably more important as you age, I think.
Absolutely. People can be very helpless, especially in the hospital.
Yeah.
And hypoglycemia may, as I'll show in a few slides, may not manifest in the same way that it does in a younger person.
Okay.
One of the factors for people that either do or do not have diabetes in older age is that the glucagon responsiveness is blunted in reaction to hypoglycemia, leaving people dependent on the epinephrine response for counter-regulation principally. And this may be a factor in why there's more risk for older patients.
But just to clarify for our audience who also understand that many times we give our patients glucagon emergency kit to treat hypoglycemia, would that still be a problem if you gave them an exogenous glucagon?
No, but someone has to see that it's needed, and that may be not the patient themselves.
That's right.
There may be blunted manifestations, dizziness or cognitive changes, and the person may not know that they need to call for help.
Right.
The glucagon is usually an agent that someone else gives to the patient, of course. Now, this was a study of a hypoglycemic clamp in people having diabetes at an older age to see whether they reported symptoms in the same way that younger people did, middle-aged people. The hormonal responses of counter-regulatory hormones were examined in this study, and they were preserved similarly in both groups, the middle-aged people and the older people. And also in both groups, even after recovery, for 30 minutes after pulling out of the low sugar, people still had delayed reaction times. But the symptoms that were reported were not reported as clearly by the older patients as they were by the younger patients. The older patients had less awareness of both autonomic symptomatology and also neuroglycopenic symptomatology compared to the younger ones. And this certainly has a bearing on their ability to call for help if they don't know that anything's happening to them. This is a study from the Kaiser Permanente registry. Let me just get this Kaiser Permanente data registry. Patients were looked at asking the question, had there been emergency room or hospital stays for severe hypoglycemia, and then were the patients known to have dementia or not to have dementia. And it appeared that there was a statistically different frequency of having had severe hypoglycemia among the patients that were known to have dementia compared to those that did not have dementia, raising the specter that what we've often thought might have been transitory problems maybe really are problems that have long-term effects, especially if they recur repeatedly, that patients have repeated episodes of hypoglycemia.
So, Susan, one of the things that I think a lot of us discuss with our patients when we're managing their diabetes at a younger age is we don't want you to have so much hypoglycemia or else you're going to end up having problems with your cognitive function later in life. Does this information support our contention?
This does seem to. It's been harder to get that kind of evidence in younger patients. It's been really hard to prove the long-term sequelae of hypoglycemia. There is not a simple test. I guess functional MRI testing can show something, but you have to ask after the fact whether previous episodes had caused any harm, and it's very hard to prove.
Right. I think this sometimes gets many of our patients frightened about tightening up their blood glucose control because they don't want to have a lot of assisted hypoglycemia, if you will. But I think this is powerful information you're sharing with us here.
Now, this is another study of patients in a very large registry in the United Kingdom. This was a proprietary registry from an EMR. Looking at patients who were older than 50. I hate to call that a geriatric population.
Yes. Please don't.
Okay.
Please don't.
And the question asked was, in the time period of follow-up from 1986 to 2008, was there a relationship between the A1C and the mortality in two different cohorts? One was a cohort where monotherapy was intensified to be a combination of metformin and sulfonylurea, and the other was a cohort that included insulin. And here is a U-shaped curve or J-shaped curve showing that the best place to be was around 7.5. The risk of a lower A1C was even greater in the insulin-based regimens than in the oral-based regimen. This seems to support the recent Accord study findings. And furthermore, the hazard ratio for progression to the first large vessel disease also showed a U-shaped curve in this study. In trying to come up with guidelines about targets for elderly patients, it's important to bear in mind that the group of people we're talking about is very heterogeneous.
Right.
We're including some people that have lived with diabetes all their life, some having type 1, and then some where you can barely see that they have diabetes. You'd have to do a glucose tolerance test to find it, and its onset might have been after age 65. In caring for these people, then we think about the duration of diabetes and the frailty of the patient. There are other comorbidities and their physical and cognitive functioning and their life expectancy. And I find it hard to suggest to the patient that they are so old that we should not try as hard.
I agree with you.
It's a hard
I agree with you.
Discussion to start, but it usually is the patient that starts the discussion if they wish to modify targets or to modify the intensity of treatment. They'll themselves suggest that one should back off from the general standards. So I tend to wait for someone to give me a cue from the family or the patient themselves. Okay. It's, of course, always appropriate to talk about risk-benefit ratio, and that is a way that the comorbidities can be brought into the discussion without offering a suggestion that the patient might prefer not to hear about whether or not you wish to intensively treat the patient. Brittle diabetes may exist in the elderly. We have always thought that brittle diabetes was an uncommon problem, right. But actually there may be a second peak of brittleness in older age among the lean type 2 diabetes patients who are old. And they may behave somewhat like the patients who have brittleness at a young age with type 1 diabetes, and in some ways there may be differences. Questionnaires were sent out in the UK to 231 consultant and geriatrician physicians who ran diabetes clinics, asking whether they had any patients that met a definition of brittleness that was offered in the questionnaire. Age over 60, insulin treated, glycemic instability leading to life disruption, or recurrent and or lengthy hospital admissions. And in response to this questionnaire, 55 cases were turned up.
Just because we are very careful about the term brittle diabetes, those 4 things that you just listed, those don't all define brittle diabetes. So I want to make sure our audience is aware that just because you're over 60 doesn't mean you have brittle diabetes, and just because you're insulin treated doesn't mean you have brittle diabetes. The other 2 things many times do reflect unstable diabetes.
Yeah, that's right. The first 2 bullet points were just criteria 15. For circulating the questionnaire to capture a population that they wanted to examine. And the respondents defined the evidence for brittleness as shown on this slide, that there were either recurrent DKA episodes or recurrent episodes of hypoglycemia or a mixture of these problems. And the types of insulin therapy that people were on included twice daily premixed biphasic insulin or twice daily self-mixed free-mixed insulin, 4 times daily basal bolus therapy, which is quite appropriate for many people with brittle diabetes, and in some cases continuous subcutaneous insulin infusion or other regimens involving insulin. So this is a mixed bag. It included some patients having type 2 diabetes but behaving like type 1.
Is it fair to say that it didn't matter what kind of insulin regimen you were on, that you still could, that any of the insulin regimens could cause? Yeah,
they didn't clearly, as I recall the article, they didn't clearly identify one type of regimen to be more likely to produce the problem. It was just a small number of responses, though, to this survey, so it may be that there could be a difference that wasn't captured in the study.
Okay.
In talking to people that do seem to have brittle diabetes and who are elderly, it's important for clinicians to bear in mind that their life expectancy may be longer than the clinician realizes. And some of these people may reap the benefits of intensive control. It probably takes about 8 years of intensification before you would see a payoff with respect to retinopathy or nephropathy. But actually, that may be worth aiming for many of these people. And many people want to give it their best shot, even though they are in an older age group. They've perhaps been used to it all their life. For many people, I find that it actually improves their quality of life tremendously to move over to an intensified regimen because it solves some of those issues that result from the brittleness. The severity of hypoglycemia may be less, for example, if one switches to insulin analogs used in a 4 times daily regimen. This may require the help of someone at home, like a loving granddaughter.
Right.
But it's remarkable how much it can help some people to make that kind of a change. And then matching the insulin to the food that is about to be eaten or that has been eaten is another strategy that often helps smooth things out. people then who want to do this should be provided with the education and the skills to do so, and should be treated with the same goals as younger adults. But it is also reasonable to set less intensive goals for people that have advanced complications of diabetes, or who have comorbidities that really limit their life expectancy, or who have severe enough cognitive impairment or functional impairment that they can't do the things needed for intensive management. It helps to use premixed insulin sometimes, and it helps to use insulin pens for some people. To help them to do what they do.
Susan, before you move this slide, this was groundbreaking information shared this year by the American Diabetes Association, which really will affect the care, I think, of some of our primary care providers in giving diabetes advice to their elderly. Was there a hemoglobin A1C value suggested, if you recollect?
To target for the elderly? Not in the ADA statement, but some other literature would say that either under 8% or not more than 40% above upper normal. That is, you could let it get close to 40% above upper normal in the elderly and still consider it reasonable control. And the standard for blood sugars that has been promulgated would be something like under 180 fasting or under 200 fasting. That roughly correlates with the renal threshold.
Right.
And it probably is when you exceed the renal threshold for most of the day that you begin to get into troubles with dehydration.
Right.
It also is above 180 that you probably have problems with wound healing and with infections more than at a lower number. So those would seem like reasonable numbers. As to postprandial, numbers in the mid-200s have been suggested to be reasonable, but actually, if one's loosening up, there's seldom a need to do postprandial monitoring.
That's right.
So the goals then would be to avoid dehydration if you are going to set a looser target, and to try at least to be sure that wound healing will be optimal, and to avoid hyperosmolar coma. Under 180 would be my personal target for the pre-meal blood sugars for people where I had decided that we could go for a looser level of control. I believe that the professional societies ought to become more formal about this, and the way that doctors are scored probably ought to include evidence that they individualize their treatments, but so far that's
I
not
actually
happening.
think that is the most important comment, also for safety, for patient safety.
Yeah. Treatment regimens. A study was designed in North Carolina, actually, drawn from the elder study of rural residents, a population-based study, where questionnaires were put out to see, of those things that one might envision that would have an impact on control, which ones really counted. There was a model where 4 self-management resources were considered possibly to be important, and 6 self-management tasks were considered to be possibly important. And then interviews were conducted with patients, and the patients were then divided into those that had really, really good control and those that had more poor control, under 6 or over 8% on the A1C. And the ones that were under 6, the things that they found did seem to count were that specific food behaviors were reported about limiting consumption of foods that could be definitely identified, and portions could be identified, whereas those with the poor control only named general food categories and talked about watching more than about doing. They said, I watch this or I watch that. Right. The people that were in good control performed regular blood glucose monitoring. Now, this might be kind of a contentious issue. And those that were in poor control did blood glucose monitoring only reactive to symptoms or when they suspected that they might be high or low. The use of home health aids was greater in those that had the better control, and less good in those that, or less used in those that had less good control. Of course, this was not a randomized trial.
Susan, in your practice, when you have patients who are on a fixed income, which defines many of our elderly patients, the blood glucose strips are some of the most expensive part of the whole management of their diabetes. What would you recommend to our listeners as to how often, based on the data you just showed us, we should recommend to our patients to check their blood sugars? I know insurance companies are paying attention to that.
Right. If somebody is taking insulin, especially multiple injections of insulin, probably a 3 times daily regimen is a minimum for people people taking multiple injections. But for somebody who's not taking multiple insulin injections on oral agents alone, in particular, there's even doubt about whether self-monitoring is helpful at all. It can show a person certainly the impact of meals and the impact of physical activity, and it can detect hypoglycemia when symptoms are present. But whether routine monitoring does or does not benefit people is still a contentious area. Some information suggesting that it does help is a little bit hard to interpret because the education on self-monitoring was offered at the same time that all other education was offered, so that it was hard to know what was responsible for the improvement. I think most of us that practice endocrinology would like to see at least 1 or 2 tests in an alternating pattern before meals and at bedtime, at least 2 or 3 days a week, and carried in showing the last week before each appointment. That's my personal.
Right. Prepare for the physician visit.
Yeah, right.
So in our last few minutes, can you share with us some of the precautions of using some of these medications?
Okay. Well, metformin has often been said to be riskier in the older patient, probably because at a given creatinine, the GFR may be more severely reduced than at the same creatinine level in a younger person. The muscle mass of the older patient is less. And there's also an increased risk of heart failure and an increased risk of true renal insufficiency. But if metformin is used within the guidelines of how it is supposed to be used, it has been used safely now in many elderly people. So it is really one of the linchpins of therapy for most elderly people that have normal renal function with type 2 diabetes. TZDs can cause fluid retention and exacerbate heart failure, so they should be not used outside of guidelines.
And you talk about pioglitazone.
Yeah, pioglitazone, yes. And then among the sulfonylureas, we mentioned avoidance of glyburide and preference for glimepiride or glipizide. The extended release of the glipizide is a good choice. Insulin use requires visual and physical manual skills or assistance from someone that can help the patient. Drugs should be started low and worked up.
Susan, you have given us remarkable insight into the management of our elderly patients. If you were to give our listeners a couple summary points, what would you like to share with them?
Well, the targets for control ought to be those that will improve quality of life for these patients. That might include attention to lower extremity problems and to vision, and maybe less attention to things that take more years to develop. We're not as sure about cardioprotective measures such as statins, and we're a little more sure about blood pressure control. We want to keep people from becoming dehydrated. We want to prevent poor wound healing from happening and reduce infection. So that I would say we could modify our goals with an emphasis on quality of life and preventing those things that are likely to occur within the lifetime of the patient.
Susan, this has been extraordinarily helpful and is on the cutting edge of some of the newest decisions that are being offered to our physicians and our extenders in the management of our growing population of elderly patients. I really appreciate you joining us today.
Thank you. It was a pleasure to be here.
Our guest faculty has been Dr. Susan Braithwaite, one of my colleagues. Susan, your conversation was remarkably helpful, and I'm sure will be useful for many of us moving forward in our care of our patients with diabetes.
Thank you.
Until next time, then, from all of us here at Duke, this is Diana McNeil saying thanks for joining us and take care.